Hi, everybody. I wanted you to be able to learn about the guide model, which will be coming out in July of 2024. It's through CMS and the Centers for Medicare and Medicaid Innovation. They have finally listened to some caregivers and said that we need something that's specifically for people with dementia to be able to get all their care there and stop this running around everywhere and people that don't know dementia. So the guide model was created. It's going to be an 8-year project, making sure that people are connected to someone that knows dementia, all types, FYI, and can take total care of a person with dementia. And so I had asked Carolyn Clevenger from Emory University and the Integrated Memory Center, which I love. We go there. She'll explain that to you, to take us through the guide model because PS, they're the model. So we love IMC, and I wouldn't have anybody but Carolyn tell you this story about how this all came to be and what it will entail for dementia families. So, Carolyn, would you like to introduce yourself?
I'd love to. Thank you so much for having me on today. I am a gerontological nurse practitioner by training. That means a nurse practitioner that only deals with older people and common conditions in aging. So I also have an adult gerontology certification to cover me for some of our younger patients, which is something I did a little later in my career. I'm a professor at the School of Nursing at Emory, and 10 years ago, I created this concept of integrated memory care with a colleague who was a wonderful partner and then went and retired on me after we opened. But we've had integrated memory care here at Emory as a joint initiative between the School of Nursing and Emory Healthcare. We've been open since 2015. And my program of research is working with dementia family caregivers on topics like helping them sort of be trained up for their role and also how to navigate all these systems we put in front of them. You may hear more about care navigation in this space, including today. So that's been my program of research. But at this point in my career, all I do is either design models of care that support people living with dementia and their families and however they define family, or work in research with caregivers.
Take it away.
I'll jump right in. Okay, so today we're going to talk about both guide model and integrated memory care, or IMC. And I'm going to try to make that the only acronym I use while we talk today. So IMC is this model that we've developed here. It is still one of a kind, the only of its kind across the United States. And at the core of it, there are these three things that happen. So we do primary care. In fact, we're defined as an advanced primary care practice, all the things you would expect to happen in primary care. We do dementia specialty care, so everything you would get from a dementia care specialist. I teach a program for nurse practitioners to become dementia care specialists, and all of our nurse practitioners are trained as such. And then also we provide services for caregivers and care partners, including education and supports. So all of that happens in one location right here at our practice, and now in senior living communities around the Metro Atlanta area. Let's see. In terms of the populations that we've served, we've been open since 2015. We've had over 2,000 patients and families at this point. And we do have a typically older population, but the range is pretty wide. So our average age is around 79, but our population is between mid-40s to 100. And we are predominantly female. About 2/3 of our patients are female. About 42% of our patients identify as minoritized populations. The largest of those are Black or African American. And then we tend to specialize in that moderate or middle stage. About 64% of our patients are in that middle stage. That's often when people either finally get a diagnosis or when their usual primary care we maybe figure out is not necessarily working for us. We do have a mix of patients in terms of dementia types. We have I would call it a slight majority, about 64% of patients with Alzheimer's disease. We absolutely see patients with frontotemporal dementia, with Lewy body disease, with vascular disease. And fun fact, your brain doesn't necessarily pick just one. So we certainly have people with multiple forms of dementia, but we're here for them regardless of what has caused it. And we've got a pretty big team. So Sharon has been with us for some time, and she's watched the growth happen over the years. So, for a long time, our first, 7 years that we were open, we had 7 employees. And we were in 700 square feet. We were like the 777. And just in the last year, we've opened up a practice in senior living communities and really expanded the team pretty dramatically. But I just wanted to illustrate, this is a nurse-led model of care. So that means nurse practitioners provide the primary care. Within our own practice, we also have geriatric psychiatry as part of the team. So they act almost like a consult, but within the practice. So they're still part of our core team. Sometimes I can just ask one of our geri psych nurse practitioners for advice. And sometimes I would really like for her to see the patient for a visit or two to help me with some things that are a little more challenging than what I'm comfortable with. We have physicians on our team as well. They're terrifically supportive of us. They do not do patient visits, but they participate in a number of other ways, probably more behind the scenes than patients might see. I think the other power is our sort of core group here at the practice. So we have program coordinators. That means people answer the phone directly when you call us, and they know you and your family. So they know which of our patients call themselves, and we know which of our care partners are probably the better person to talk to about logistics and scheduling. Our social workers are just incredible. They do psychotherapy, teach classes, coordinate care, and then registered nurses as well, who also do certain types of visits that are focused on prevention, but also can triage those concerns. So that means any time of day. We also have after hours line, but certainly during business days, you call us, someone is going to answer the phone or get right back with you and get you to the person that you need. That's been really important to us, because even though I founded the practice, it's important for me to remember and remind the team that we're caregiver initiated. That's who came up with the idea for this model. I didn't come up with this on my own. I had a sense that things weren't working, and I went right to family care partners and I said, you tell me, how would you design a model if you could? And then I put something together that would work in our health system today. So that's IMC. Anything else I should say about IMC before we move on?
Yeah, I think you should talk about the community. I think you should talk about what you have done to expand IMC to service more people, and also about your area that you serve.
Sure. So to become a patient at IMC, we do talk with you about the practice because it's different, and there are some eligibility requirements. Most of all, the requirement to be a patient in our practice is that you have a dementia diagnosis of any kind. And we realize how challenging getting that diagnosis can be. And so if you don't have something that's more clear in your last visit note with a provider, any provider, doesn't have to be a neurologist, primary care is fine. If it's really unclear and you're having challenges, we'll try to work with you to understand what's been happening. What is the symptom progression over time? Sometimes, look, it walks like a duck, talks like a duck. It's a duck, right? So we don't need to let those other practices hold you up too far, but that's what we're looking for first and foremost. And next is that you understand you're changing primary care. So you can't also have primary care and then also see us as primary care. Primary means one. So that's the biggest piece of it. We're located here in Metro Atlanta, and we largely serve people in Metro Atlanta. We do have people who come from a further distance, but they just need to know they're going to come into the practice. We want to see people, and we see people pretty frequently, minimum of 4 times a year once someone is established, and getting established usually takes a couple of visits. We want to get to know you. We want to get to know your care partner to make sure that we're setting you up for the services that make sense. Now, the reason we tripled the team last year is that we also now go into select senior living communities in the Metro Atlanta area. We are actually looking for additional senior living communities, and that might be an assisted living, could be a personal care home, could be a senior high rise, but it is not nursing home. So in those communities, we not only have that nurse practitioner who's doing your primary care, dementia care, all in one visit, we also have an occupational therapist as part of that team. And then we have this incredible workforce that we've created called a dementia care assistant. And these are individuals who meet with your person one-on-one at least once a week. Some people get it twice a week, and they do companionship. Truly, this is a person who spends time with you or our patient, our participant, as we call them, and they do activities that are tailored for them. They're tailored to their preferences, to their level of ability, not too challenging, but not too childlike, right? And at the end of their time with our participant, their only goal from me as their boss, right? What they hear from me is, At the end of the time together, that person needs to have had a positive emotional response to the experience. So if they're very anxious that day, they may just sit quietly with that person and hold their hand. If they're feeling more active, we might do physical activity if that's the priority. We might do sorting games. We might work with a doll as doll therapy. We might do puzzles. We might do a hydration station if we're worried about that. So that plan, of course, is outlined by our nurse practitioner and occupational therapist. And then that dementia care assistant can come up with different tools in their toolkit to make sure that person has a good time. It's like having a good friend who knows you, who's coming to spend time with you each week. It's really been remarkable to hear the experiences of our patients or participants and their families of just they just really adore their special person, their dementia care assistant. So that's been very exciting.
That's very exciting. And it was very exciting for us that have been involved with the clinic for some time to know that you can also go into the community, because a lot of times, when you have someone in community, they're seeing the doctor that's there, they don't know them. All of a sudden they're on medications that you're a little bit skeptical about. So this enters someone who knows you, knows the person with dementia, knows what's going on, and they see them on a regular basis and sort of help that facility along in understanding what this person needs. This is what facilities should be doing all the time, but we all know that that doesn't happen all of the time in all facilities. So this has been a great contribution to the community for those that are living either in assisted living or memory care to have the same outstanding care that you get at the integrated memory clinic. And P.S. I'm not employed by them. I am simply a care partner for a patient that sees the nurse practitioners at IMC, and I wouldn't change for $1 million. It's the best thing that ever happened to us. So if you're in the Atlanta area or Georgia, reach out to IMC and see if you would like to be part of their integrated memory clinic. So knowing that this model of the clinic was used sort of as a guide, Carolyn is going to go through what that guide model is, because you'll hear the name used. You'll go, what the heck is that? How can I be involved? Where is it? So Carolyn, take it away and tell us about guide.
Sure. So this has happened in the last few years that integrated memory care got a new sort of name, or I should say a label that we didn't necessarily come up with originally. And that is we fall into a category called a comprehensive dementia care model. You've heard what we do. We do all of the things, right? We try to keep all the things in one place. We design the team around what our patients and families said that they needed. So our goal has always comprehensive, fits really well for us. But this is an actual not just label, but there's a definition of what that means. There are these 8 core elements. And but it puts us in a category with 5 other practices around the country. And so what I'm showing here is from our article, an article that was published in Health Affairs. And in Health Affairs, they have a table, and this is actually a replication, an updated version of something that was in a report by a group called the Alliance to Improve Dementia Care. I'll show that in just a second. So it compares all of these models around who staffs them, whether they do face-to-face, do they have 24/7 access, does the practice communicate back to your primary care? For us, that would be not applicable because we are your primary care. So yes, we communicate every morning, 8 a.m. huddle. Do we write orders? Do we manage medications? All of those things. And then the lower half talks about some of our published outcomes. So can we actually say that we provide high quality of care? And that means that we meet those published quality measures, that we've demonstrated benefits both to the patient and to the caregiver. And then there's questions around how much do we spend on the program and how much does the program save? In my experience here and with other models, when you make a larger investment, you tend to get a bigger savings. Those do correspond with each other. And we have a really robust team here that does phenomenal work. But that's an investment, but we save a lot of money, not just to Medicare, but also to families. So we got lumped into with this group, which was fantastic. And it was based on a couple of things about our outcomes. So one of the things that we were able to publish early in the academic literature, this was in Journal of American Geriatric Society early on. We just looked at our first 100 patients, and it looked like we were really effective at avoiding emergency department and hospital stays. And that's great. But as you can imagine in research, and it doesn't take a researcher to know, you need to compare that to other people who weren't in your practice. So in the last few years, and COVID, of course, slowed us down getting the data and getting an analyst who could pull the data. We compared it to other patients who had primary care and did not have a dementia specialist at all. And then we compared it to people who had primary care and had a dementia specialist, but they weren't in the same practice. And we saw a significantly better a way to avoid hospitalizations. So we really lower that risk of hospitalizations. We have presented that at the Alzheimer's Association's International Conference. We have a written publication pending. And then we also avoid prescribing really harmful drugs. So I know sometimes in behavior variant FTD, for example, people love throwing some heavy hitter drugs at this, which there may be a role for medication in addition to probably some other things. And that's a shared decision that we would make between families and patients and our providers. But as it turns out, when you see multiple providers, nobody quite owns that prescription, which means people are hesitant to stop that prescription. So we looked at people who came in on high-risk drugs and how effective we were. We were 10 to 13 times more likely to deprescribe it. We were really good at avoiding inappropriate screenings. I know colonoscopy seems harmless, but it does carry some risk. And so there should be some benefit for you if you're going to take that on. So, and really high patient and family experience. Sharon's going to be our poster child. I should be paying you probably. But we did reduce distress for our family care partners, even when we weren't able to necessarily change the symptom. Sometimes understanding it and knowing how you'll cope with it and manage it is very helpful in and of itself. So we had these published outcomes. That's one of the ways we were able to be part of that list. So that report was the first thing that really, I think, put us in a group with these other models under comprehensive dementia care. And that's the Alliance to Improve Dementia Care. That's out of the Milken Institute in their report, Scaling Comprehensive Dementia Care Models. And the question in that report is, so we have these models, they've been established, some of them are in multiple places. They've demonstrated that they're effective in all of these ways that mean something to all of the stakeholders. They're meaningful to Medicare, they're meaningful to patients and families. Frankly, I think my team has higher engagement and quality of life at work because of the work that we do. So why aren't they scaling? And one of the core reasons is that Medicare reimburses traditionally for, I did a service, I got paid. And by the way, a service of counseling and coaching and doing basic, excellent primary care does not pay as much as if I put a pacemaker in you. So it's a challenge. And so that was the core of that piece. And it prompted a meeting. So each of our model representatives were invited to a face-to-face meeting in DC last fall in 2022 with CMMI, so Centers for Medicare and Medicaid Innovation. And their questions were things like, we hear you, this makes sense. They in fact funded some of the other models. Ours was actually seed funded by family caregivers, but the other folks did get grant funding. And so if CMMI has grant funded you and you've been successful, they'd like to see it scale too. So we were all, I think, in agreement that we would like to see this happen and that an alternative way of paying for these services might make more sense. Something more aligned with what we call value-based payment, which is here's a flat amount of money. You do the things you need to do to take care of this patient population, and can you get the outcomes and how you figure out how to use it. So they asked us things like, well, how would we designate a practice as being a guide? Oh, no, they didn't call it guide back then. Let's call it a comprehensive dementia care back then, right? So what would make that criteria? And so we're a patient-centered medical home as well. There are criteria for recognizing a practice as a patient-centered medical home. And those were my suggestions. So you could look at core elements and be recognized that way. Well, if we require that you offer caregiver education, what caregiver education? Well, you can't just like throw together a caregiver class and say, oh, look, we got caregiver education. It needs to have evidence base as well. So there is actually a list called Best Practice for Caregivers. Family Caregiver Alliance manages that list. You'll see our practice on there and others and other programs there that have shown an actual change in outcomes for the person who took the class. So we talked about that. So it was a lot of the logistics. What would be included? What wouldn't be included? That remains unanswered. I'll get to that in a minute. So that was a very, I was really encouraged by that day. I thought we were really making some meaningful progress. Their questions were not like, should we do this or shouldn't we do this? Their questions were, how would we do this? And the room had a number of, I think, very helpful and specific logistical suggestions for how to roll this out. And then as a group, we also had some public information out there. The health affairs article that you just saw came out very quickly after. We were in CBS News, Forbes, which was probably my favorite article. And then end of July, it's a Thursday, I get an email inviting me to this advisory committee on Monday. And I was like, this is a little bit random that I'm getting this invitation to a meeting in 2 days. And, my calendar wasn't open, let's just say. So I cleared some things out. I thought, let me get on here, 9 o'clock. And this is an advisory council as part of the Department of Health and Human Services on Alzheimer's disease and care. And when I get on there, they have changed the agenda for the day because they made room for this announcement about what they're calling GUIDE, which is actually an acronym, of course, Guiding an Improved Dementia Experience. And so July 31st, then we have this program out. So let's talk a little bit about what GUIDE program is about. So really, there are just a couple of goals for GUIDE. One is to improve quality of life for people who are living with dementia and their caregivers. The next is then to reduce that caregiver strain and burden. If you haven't been paying attention, I think you may have missed that our family caregivers are the backbone of dementia care in this country. Without them, we would absolutely collapse. So preserving their well-being is really important to lots of us. And then ultimately to keep people in their homes and communities. So avoiding ultimately nursing home placement. There are both family reasons and financial reasons to do that. So it is an alternative payment model. It will replace certain billing codes that I would have normally used. So I would say I'm doing this service and I have to drop this charge, and some billing and coding person in my health system is going to review the note, make sure I hit all the elements, and they may or may not let me charge for that. And then the insurance pays what they pay. So we're getting away from that. We're going to a monthly amount for the practice to do the things that are required to stay in this program. And also, there is this separate payment for respite, and that is daytime respite and overnight respite. It's capped at $2,500 a year. We are aware that we will be working here with our partner day programs and our assisted livings, where we have our community program today, to make sure that families who are using that benefit can maximize how much of that benefit they can use over the year. So we'll be working on some nightly rates probably for our families. When you apply to be a GUIDE practice, they only want one organization to be the GUIDE practice. Now, that doesn't mean that in your part of the world, or your part of the country, that you might have a practice or a health system, and then they have partnering organizations that maybe meet the other needs. Here at IMC, we've been big on doing all the things. So we don't have to partner with other groups. We might, because we call ourselves Dean's List because we're a bit of overachievers. So if there's anything that we would benefit from by partnering, we will. But ultimately, it's one practice. There are 2 tracks. So Sharon mentioned that this begins July 1st of 2024. That is if you are an established program. So if you're an IMC and you've been doing this work for 8 years, I guess it'll be 9 years by then we would go in as an established track, right? We already do all of the things. We've staffed it. All of our people are trained. We've got our workflows. I mean, 8-9 years of learning at this point. But maybe you want to start a new practice, and there are so many places around the US that want to start a new one. And so they then would be selected July 1, and then they have 12 months to get ready. So they'll actually start providing that care in July 1 of 2025. In terms of how you staff it, you don't have to have a big org chart like I do. You staff it the way that makes sense for your practice and your program. But there are 2 people who are required. One is that care navigator, which I've not yet seen well defined. So that typically is social work or a registered nurse who function as a care navigator. And then the others, you have to have a dementia proficient clinician. So Sharon, I believe you described that as somebody who knows what they're talking about with dementia.
Right. And you and I both know, and the people that are watching this that are care partners know that that's not, you have to find the right person. We all know that, and we all know that we've been in bad places before. So this is such an exciting thing for people that haven't gotten good care from people that know what they're talking about.
Mm-hmm. Now, they do define dementia proficient clinician. So that is defined as someone who has a significant, it's like greater than 25% of their patient population has a dementia diagnosis. There's something about time in practice, I think. There's a second piece. And then that they're board certified, which we're big believers in this, in geriatrics or neurology or geriatric psychiatry or something related. So that's been a big piece for us. All of our nurse practitioners, as I mentioned, are certified. Our physicians are board certified in geriatrics or neurology, like that. Even our nurses are dementia and palliative education trained. So that is well defined. We'll see what happens with the care navigator. There's ongoing conversation there. Now, when you get value-based payments, you are held to certain outcomes. I'll show you in just a moment what those outcomes are. But what happens in this program is after the first year that you've been open, you'll be measured on those, your performance is there, and it's compared with other guide practices. So if you're performing well, you get a little bit more the next year. If you're underperforming, you get less. So will be interesting to see how that sort of plays out. That's a common calculation that Medicare has been using in value-based programs for a while.
And I think that that's really important. I think that's important to families to know that these programs are going to be monitored. And if they're not living up to what Guide expects it to be, then they're going to get hit with a little bit lower payment because they haven't met all that criteria. So if you are fortunate enough to be in an area that becomes a guide model, you know for a fact that they are meeting what is needed by people with dementia and their care partners and their families, and how this relieves the stress of all of those people.
Yeah. So there are some required components I'll share with you in just a second. In terms of what those practices can be, I mentioned it's a single site. So in our case, it'll probably just be us. Whether you're established or new, there is a program director. So someone like me or someone who's working here who oversees that practice. There has to be a staffing plan that we'll have to submit, and you have to submit your protocols and workflows, and then also a referral network. So at the moment, practices like us are waiting to hear a formal, what's called an RFA, which is a request for applications. And so that we'll be applying, and I think we'll see a lot more detail, but you can't sort of say, I mean, I'd like to be like, look, we've been doing this 8 years, see my publications, I'm established, but they're actually going to want to see what we have in place here to demonstrate that we get to be selected as a guide site. I also don't know if they will accept everyone who has the program components, or if they will say, we're only going to do, I don't know, 200, right? So we'll be interested to see. I think the important thing though is for patients and families here, which is who gets to participate as a guide patient. We've been told that we will have to submit each patient for approval to be accepted in the program. I doubt that's really going to like individually happen. I think it's more, we would have to document what makes you eligible. So you do have to be traditional fee-for-service Medicare Part B, right? So if you're Medicare Advantage or you have Medicare through a private insurer, you do not have access to this program. Now, if you're an IMC patient, you're still going to get all the services. You just won't get that respite. But if otherwise, if you're not at one of these type of comprehensive dementia care practices, then it really makes it challenging. Now, each site should have at least 200 patients. That's the expectation. And so again, it's kind of like if you're familiar with going in for like a surgery, for example, you want to go to a surgical center that does thousands of these procedures, not 5 or 10. I think it'll be a good thing if you're in part of a practice where there's a critical mass of patients. If your team is new, they're going to get much more adept at managing and workflows as long as they've got a large group. You will probably have to sign a consent to be a patient because this is going to change the way Medicare reimburses your practice. And in the last few years, anytime a new payment structure has been rolled out, like chronic care management, for example, which is a monthly charge, not a daily or service-based charge, you are asked to consent to that as well. So you'll be asked to consent. You don't have to have a caregiver care partner. So some practices require that. We don't. Certainly, it's helpful to have that person who's supporting you and making sure the care plan happens. But in order to be a guide patient, it's not required. And then you are placed in our world into what we call risk stratification. So that means depending on how much need there is, the monthly payment's a little bit different to our practice. So you might be asked things like this, and this may give you some idea why, right? So there's the stage of the dementia, for example, mild versus moderate or severe. There is how much strain the caregiver care partner is experiencing. They're going to, it looks like, use a specific tool to measure that, which is called the Zaret Burden Inventory. And then whether you have a caregiver or do not have a caregiver. So that will change what risk you're in. That is not necessarily a bad thing. I think for your practice will actually be paid more if you have more advanced dementia and no caregiver, because they will be needing to spend a lot more time coordinating care on your behalf. So the core components are really this. So there's care coordination and management. So that means not just of your dementia, but it says co-occurring. I don't quite know what that means for other places yet. I think this is one of those details we'll see in that request for applications, or RFA. In my opinion, well, not just my opinion, in my clinical experience, your brain, it turns out, is connected to the rest of your body. So when we say co-occurring conditions, do we only mean like psychological symptoms of dementia, or do we mean insomnia, which is disrupted sleep pattern, or REM behavioral sleep disturbance for our Lewy body patients? Your blood pressure matters for your brain, your diabetes matters, your low thyroid. In fact, your ingrown toenail, if it's not treated, causes pain, changes the way you walk, you're more likely to have a fall. All that's connected to your cognitive performance. So again, this is why IMC exists, but I don't know quite what that's going to mean. It is ongoing monitoring and support. And what we mean by that is, and Sharon and I have used this phrase for a while, that idea of like diagnose and adios. This is not what this is about. These people are post-diagnosis, and it's ongoing monitor and support. So there's the caregiver education and support. So maybe that includes skills training for this job that you may now find yourself in, and you didn't go to nursing school. It's education on the diagnosis itself. It may include support groups, and then that respite that I mentioned earlier. So those are the sort of big components. They match very closely to those 8 elements of comprehensive dementia care. And as it turns out, we have all of those plus a lot more. So we'll have to kind of figure out what that means for IMC. Here's sort of another sort of visual. You can see this on the CMMI site in terms of everything that your team is expected to provide. So it is that assessment, and we don't just mean of your thinking, we mean, are there challenges with housing security regardless of the dementia? Are there neighborhood concerns? What's the support network look like? You should have a written care plan that tells you these are the priorities for you. These are the priorities maybe you've outlined for yourself. These are the priorities that your clinician thinks are important. And here's some action steps that you might want to follow in the next few months. Everybody has to provide 24/7 access. We've been doing this the whole time. I mean, Sharon knows. Oh, I think you're on mute, Sharon.
That's because the outside maintenance people are doing the grass. I'm sorry if you hear that. Of course, I have no say over that. But the one thing with the integrated memory clinic that we have used multiple times is that 24/7 line. And when I call that 24/7 access line for the IMC, I actually get a nurse practitioner who has access to our records. Although most of us know, because as you all know, Rod is famous. Everybody knows Rod. Oh, that's FTD. So when I call, I get a nurse practitioner, and I usually call after hours, sometimes middle of the night, when he has decided to kick his imaginary ball off the bed, and he just himself into the wall. And I call and say, do I need to take him to the emergency room?
Right.
And of course, I'm asked, did he hit his head? A series of questions. And the other thing is, I could say to that emergency room physician that I am that my husband is a patient at Integrated Memory Clinic. If they have questions about any of his care, integrated memory clinic are the people that they need to speak with. So it gives me this real sense of they're involved even when the care is not in their clinic. So that to me was a very important part of the integrated memory clinic. And I'm so happy that the 24/7 access has become part of the guide model. I think it's necessary for caregivers to have somebody that they can call in the middle of the night and say, what do I do? And I think that's very, very important.
I think that's a great point, Sharon. I've been talking with some other folks about what is it that really has helped us keep this hospitalization rate as low as it is. And it's not that we're deterring people from going to the hospital if they need to, but there is sort of also first the understanding that it can be not necessarily the ideal place for someone with dementia. If they have if he had hit his head or if he had broken a leg and we got a bone protruding, you got to go. But can we wait a second? So I think there's also that sense of support that we hope to provide people, and they know, okay, so right this minute, I can also give people things to watch for as time evolves. And if this does happen, then go. If it doesn't, it sounds like we can wait a minute, because you can get me again on the phone if we need to sort of re-examine our decision and make a decision. Do they just come into the clinic tomorrow, and so forth? I think that's also that care coordination piece that we do, right? So this care coordination and transition. So we are judicious about our use of specialists because they're not necessarily dementia friendly either. And so if I am sending someone for diabetes care, I'm pretty clear about what it is that I'm sending them for. What is the question that I have to that specialist? I think specialists typically appreciate that versus someone just shows up on their schedule. And if there are questions about treatment decisions and care, please reach back out to me, because I'm probably going to have more success implementing a change if you want to do, for example, injections now instead of an oral tablet for their diabetes. Let me kind of work to coordinate and make that happen for this person. Certainly, they've never negotiated through assisted living orders, for example. That's a whole different world of its own. So yeah, we're glad to be that person. It just generally works out better for us and our patients. There are financial implications for practices, and I think there's a lot of interest. The fact that you can do alternative payment models really has raised the awareness among health systems that maybe this is something we can do. It is per member per month, like I mentioned, at a particular rate. It means we can't bill other things like a cognitive assessment visit, for example. I hope you're getting those at least once a year in other practices. That's really clear. Like I mentioned, there are other things that I think are absolutely critical for good dementia care, and I don't know if they're included. So an advanced care planning visit, for example, is that considered part of dementia care? Your good primary care, that should happen. So other things like your flu shots. These are the questions, by the way, I had at that meeting in fall of 22, and I think they were heard. And I was, like I mentioned, on the call when this was announced. I have both watched and rewatched the CMMI webinar on the topic. I was on a meeting, Sharon and I were both on a meeting where they presented and I had this question, and I'm co-presenting with them at a meeting in November. I think we will not know the answers to these things until that RFA comes out. But for practices, they also recognize there's additional adjustment in the reimbursement for things for people who are very high risk. So people who live in a rural environment, safety net health systems, and then, like I mentioned, there's a little bit of payment for performance after the first year. These are the payment amounts. This is what Medicare is going to pay to your practice. The only reason I want to share this is this was, again, a discussion in fall of 22. I had some feelings about it, but the payment is a particular rate for 6 months, and then it goes down for the next 6 months. We have some research here at IMC that when people come in new to the practice, it takes between 3 and 6 months to get them settled in. So that means to sort of really understand what we're facing, to begin to understand the plan, to deprescribe drugs that might have been actually worsening the cognitive symptoms, and we kind of get settled. I don't know that people have fewer needs after first 6 months, right? People have ongoing care coordination needs, and that was kind of our answer. So CMMI said, well, is it that people need more payment up front until they're settled in and then things are fine? Or is it that the payment needs to go up as their stage of dementia increases? And I feel like all of our model developers were on the same page with this. There are always needs. That's how this disease and syndrome works, unfortunately. The type of need changes, but the volume does not necessarily change. But this is the payment structure, at least as it's coming out for next year. The performance metrics, this is what you're held to. So 5 of them. The first is quality of life. So that means if you're a guide patient, Medicare or your practice will be pushing out a survey. They will need a response to this questionnaire about quality of life. So the idea, and not that it has to get better, but they really want to know, do guide programs that are doing well improve your quality of life and your person's quality of life? They want to know if it reduces caregiver burden. And they want, now the other things they'll watch for, and that is our behavior on deprescribing of those high-risk drugs in particular. This is still a Medicare program, so total cost of care really matters. What is the number one thing that drives up your total cost of care? Hospitalization. Number 2 is probably nursing home placement. So, and that is the 5th one. So what you'll see then in those 5 performance metrics will be ranked against one another. People who perform very well, and I don't know whether that's the top quartile, the top quintile, they'll get this bonus payment. If you're performing very poorly, you'll be deducted 3.5%. So you certainly you get a lot more for performing well. I think there's also a concern that health systems that are not necessarily well resourced are really going to have challenges in so many other ways. And so they don't want to take a whole 10% from them because they may just drop the program. So it's enough of a consequence that it matters, but it's not so harmful that they wouldn't be able to be financially viable. And the last thing to remember, go ahead.
Go ahead with that. And then I'll.
Yeah. So the last thing to remember is that this is 8-year demonstration project. I almost think about it like a long clinical trial. So we are comparing the data on these patients compared against similar patients. Medicare has data on, or billing data on all of its beneficiaries. So they can match by age and race and gender, and even probably what I call risk, meaning how many other medical problems they have. And they can say whether people who were in guide programs did ultimately fare better, especially on the things that they can look at, which is mostly like prescribing, things that are on claims, prescribing, hospital use, and nursing home use, compared to people who are not enrolled. And the fact whether or not this demonstration project is effective, that determines whether this is permanent. So until we know, in my world, we know these as G codes. So these are Medicare codes that are temporary. They don't have permanent codes yet until we say whether this works.
Go back a slide, Carolyn, because I want to
Sure.
point a couple things out there. And this guide performance metric, if you become part of a guide place that has become a guide model, when you get these surveys, please remember that this model will only go forward if it's showing improvement. And so make sure that you realistically answer these questions and don't have, if you've had one bad experience with your guide model, don't say that the quality of life of your person is bad. Be realistic about what this is. I think it's important for those filling out these questionnaires to be very realistic, and I don't see how you cannot benefit from this guide model. The $2,500 in respite care alone, I would give anybody a 5-star review if they gave me $2,500 a year for respite. I mean, come on. You know that oftentimes the grants you get are $500 to $1,000. $500 doesn't even pay for overnight in a hotel anymore with a decent meal. And let's not even discuss the fact that you might want a massage. So those are things that we really need, that big amount of money. It's not a huge amount of money, but wow, is it better than most of the grants that you can get. So keep that in mind when you fill out these questionnaires, that what are you getting out of this guide model? So I just want care partners to understand that this will all be connected. And if you are fortunate enough to have a guide model in your area, please pay attention to how much it really is helping you. Okay, go ahead, Carolyn.
No, that you got it on nail on the head. So realistic, I think, is the key word. We really want to know. Sometimes people will fill out questionnaires about their person and they're just overly optimistic and then wonder why they're not eligible for benefits to support them. I'm like, well, based on your answers here, you don't need any support. So yes, just honest and realistic. Absolutely. We want to know what's working. I think for us, just to mention sort of how that might work, just to give you an example. So here at IMC, not all of our patients will be eligible either. The practice obviously meets all of Guide plus some. We're the overachievers on the far end of that table. Call that Dean's List. But it looks like about half, somewhere between 50 and 60% of our patients are Medicare Advantage. And once you're Medicare Advantage, it's incredibly difficult to switch back to traditional. So in our practice, we'll end up having sort of a little bit of a breakout, right? So it'll be like a practice within a practice. And I've talked to a number of health systems around the country in the past month. I talked to one 3 days ago, and they were trying to figure out how to make this happen. And so what I had suggested to them is something similar. So there's sort of a program director who's coordinating this as a population, because they're going to have to make sure that your billing is done correctly, that that they're not dropping charges that they're not allowed to drop, that you're getting all the services you're supposed to get, all that sort of thing. So they're gonna have to make some adjustments in flow. So you might be a Guide patient, but the whole practice may not be doing just Guide. I think that is it for the slides, but I'm sure I've forgotten something. Oh, let me get you off mute again.
Brief. They're done now, so I can stay off
Of course.
Mute. But I think you've hit on all the high points of what Guide will be, so that if people see that practices are becoming Guide models in their area, they know what to expect. I think it's important to have that education before you say yes to a Guide model. I always believe that care partners and families with someone with dementia need all the information they can get prior to making decisions. So I really appreciate you spending this time with me, Carolyn, and going through what Guide actually means, and that your model at the Integrated Memory Clinic has become the outstanding model, even in CMMI standards. So I'm so happy that you were able to participate. I'm so happy that you became part of the Alliance, and you have always been a champion for people with all types of dementia. I can't say enough about the clinic. Like I said, I'm not paid, but the care that you receive and the personalization, this Guide model is going to give you something you have never experienced something like a Guide model. If you are in the dementia community, you've never experienced this type of care. So if you have a Guide model in your area, because we're talking about everybody here, if you're in Georgia, reach out to IMC. They already have it. You don't even have to be qualified for Guide. So always reach out to IMC if you're in Georgia. But if you're somewhere else and you have a Guide model coming into your area, please try to become involved with it, because it will be important, and especially for those people that have related dementias, little redheaded stepchildren of frontotemporal and Lewy body and vascular, and all the ones that aren't Alzheimer's, the big old elephant in the room. Not that their needs are less, it's just that we talk about them more. And anybody that's heard me talk knows that it's really disheartening when people talk about dementia associated with elder and age, which was my comment to CMMI when they presented, and it was brought out. They didn't select it as a question, but the person in charge of the Alliance said, you need to answer this question about why are you eliminating young onset who may not have Medicare A and B, because for Social Security disability insurance, you are not qualified to get Medicare for 2 full years. I have been forcefully trying to get that dropped for 8 years, but unfortunately things don't happen very quickly when you're dealing with the big umbrella of government. So I can't retire until that, and I'm getting a little long in the tooth, so they need to do something about that. That's one of the things that I have to see happen, that for Social Security disability insurance, for those under the age of 65 that are not eligible for Medicare, have that weight dropped. These people have the same disease as those over 65, and actually it's age discrimination, if you want my honest opinion. So that's my part of this whole guide model, is that I'm dismayed that some of you that are not yet on Medicare and are on Social Security disability will not be able to take advantage of this excellent care. But at least this is a step forward. And with the government, you have to be grateful for any step forward. So once again, Carolyn, I thank you very much for sharing this information. And I hope the community now will understand, if they have a guide model be created in their area, that it's a very good way for them to get excellent care and for the whole family, and to have that respite amount that at least will pay for you to do an overnight respite. So thank you once again, Carolyn. And I hope all of you will take note of this presentation. I'm going to put it on YouTube, so you can go there, share it, let people know what guide model is, and we hope that this gave you some additional information about what to expect from guide, how to get in guide, what guide means, and if you're in Georgia, that you're going to contact the IMC and find out how you can be part of guide before it's even out there, except the 2,500. You'll get that when you get into the guide. But thank you again, Carolyn. All of you have a wonderful day. Reach out to me if you have any additional questions, or put them in the comments in YouTube, and we'll be happy to answer any additional questions that you have. Have a good day.